America, girl, you're in trouble. The top cause of maternal mortality in the United States remains mental health disorders. And why this conversation was very lopsided was because they didn't talk about, well, what are the risks of not being treated? It was the discussion that has a specific agenda, that use certain taglines, that use certain tag words to signal to the public certain messages when it really was propaganda masqueraded as truth. But then you have populations that don't even have access to it in this current day and time. They do not have access to a therapist. Minoritized populations that are more likely to be impacted by postpartum or perinatal depression. But when you look at the panelists, in essence, I think this conversation was way more harmful than it was at all helpful. I could write a thesis on this, but I'm not going to write a thesis on this. I'm going to say this very simple and very straight. To the individual who made this statement, that women just simply have more intense emotions. Listen, if you have depression or know someone who has depression or has been affected by any mood disorder, this conversation is for you. There's so many things that you need to know. Access to your medication may be changing, and you need to understand why. Listen, I laid everything out in this conversation, but if you want to skip to the chapters, you can. If there's specific questions you want answered, we laid out the chapters so you can go directly to that information. But if you want a full view of what this conversation was about and why it was so harmful, definitely stay tuned. And don't forget to click the like button and definitely subscribe. Hey, you guys. So we are back together again, and this is probably one of the most important discussions we will have this entire year. If you are not aware, there was a recent panel discussion hosted by the FDA on July the 21st, in which the panelists discussed the role and efficacy of SSRIs in pregnancy for the treatment of postpartum depression. That was the primary focus. There was not much discussion on other mental health disorders that are prevalent in pregnancy, which includes your postpartum anxiety disorders, your obsessive compulsive disorder, and to a much lesser, but definitely not less serious, the postpartum psychosis. So today we're going to focus on the discussion and its accuracy, transparency, its completeness in discussing this particular topic. I am certainly glad I looked at the discussion for myself because there was a immediate backlash, and I want to say really backlash, but an immediate outrage from the medical community, including the American College of OBGYN putting out a full statement, sort of confirming their position when it comes to the use of SSRI during pregnancy. Going through that whole topic, it's in its entirety is very lengthy. So what I'm going to focus on today's discussion is really talking about what was discussed in the panel and what was seemingly left out. I will say at the end of looking at the entire discussion, there are definitely some overlap, and I don't want it to seem like there is outrage from the medical community just because there's a discussion that is not favorable for medications, because that's not at all the case. The case is the fact that a lot of individuals in the medical community feel that this was a very one-sided discussion. And when we say one-sided, meaning it only presented the data to give a certain view when it comes to SSRIs and medications used during pregnancy or during the perinatal period. There wasn't much discussion on the postpartum population, which was kind of interesting because the large majority of patients who are on these medications during the perinatal period are on the medications during the postpartum period. And there was really not much discussion from that perspective. So that was rather interesting, but I'm going to focus on what was actually said. Let's start here. There are things that we all agree on. It is without a doubt that the entire medical community agrees that postpartum and perinatal depression anxiety disorders are serious conditions and warrants extreme attention, not just because of the need for additional information and scientific backing of what we currently do, but also because these conditions have very serious outcomes. And that is one particular area that I wish was expounded on more during this panel discussion. And I will explain why and give you guys some clips so that you can hear certain things for yourself. And certainly, I recommend that you listen to the entire panel discussion in its entirety, especially if you are of the scientific community, just simply because you will hear for yourself um, what was said and can make your own assessment as well. This is really to highlight certain things for you. So when you are listening to that discussion, you have a more complete perspective on what should have been talked about and what information was not actually shared. So there are a couple of things we agree on, and one is the seriousness of perinatal mood disorders and how prevalent they are. And probably still we have an underestimation on the actual true prevalence, especially in certain communities, and I will explain why. What we do know is that it has been estimated that up to 20% of pregnancies are affected by postpartum anxiety. And the number of individuals that have been affected by perinatal depression. I want to focus on perinatal because the experience of depressive disorders can occur before the pregnancy, during the pregnancy, and after the pregnancy, with the largest prevalence of individuals experiencing these disorders or depression, post-perinatal depression during the postpartum period. Within a decade, the prevalence of perinatal, or what was initially termed as postpartum depression, has increased significantly from a rate of 9.4% in 2010 to a rate of 19.2% in 2021. So there you have a very significant rise in the prevalence of postpartum depression diagnosis. Now, here's the thing. I say diagnosis, and the reason why I make that distinction is the fact that the increased prevalence may not necessarily be an increase in the actual occurrence of the disorder, but maybe a reflection of the improvement in diagnosing the disorder and the improvement in just public awareness. You have much more moms who are aware of the signs and symptoms, or at least the classic signs of symptoms of perinatal depression, and are more likely to seek help, and you certainly have a much more informed and structured healthcare community that is actively screening for these disorders. However, we are still under screening. So we are still having a under optimal screening rate in the United States. It is estimated that less than 20% of individuals are actually screened for postpartum mood disorders or perinatal mood disorders. It is also known that 15% of individuals receive treatment for postpartum depression. We also know that 13% receive treatment for depression during pregnancy, and less than 9% receive adequate treatment. So less than 5% achieve actual remission. So the seriousness of this condition should definitely not be underestimated. And we should also not overestimate where we are when it comes to managing these particular disorders. Of note, and probably the most serious statistic, is that the CDC has made known that the top cause of maternal mortality in the United States remains mental health disorders, which includes substance abuse and suicide, or someone self-unaliving. Another topic that I agree with the panel is that informed consent should definitely be a top priority. It is never okay to, in any way, biasly swayed an individual towards the use of any modality for treatment without thorough discussion on the three things we've talked about on this platform. Whenever you are approached with a decision making to undergo some type of intervention, whether it's medical, surgical, or some other type of therapeutic intervention, it is always important to ask three very important questions. What are the benefits of the intervention that's being proposed? What are the potential risks of the intervention? And the third thing would be, what would my alternative be? And every clinician should be able to comfortably answer all three of those questions. If not, they are not the appropriate person to be having that discussion with you. We have found this discussion of perinatal mood disorders so important on this platform that we have discussed this topic several times. And a matter of fact, the first time I really talked about the outcome or potential outcomes in the offspring or the children of moms who are affected by perinatal mood disorders or some type of traumatic event was in the initial discussion about the outcomes of the children of 9/11. And that was several years ago. So let's start with fetal programming. Have you ever heard of fetal programming? Well, fetal programming or prenatal programming is the concept that suggests that certain events occurring at very critical times during the pregnancy actually has permanent effects on the fetus and the infant long after birth. So we have definitely proven on this platform that we find mood disorders to be so important to our public, to our viewers, and definitely to our community that we have built here. The other thing that I agree with the panelists on is the fact that there is definitely need for continued research. Now, we have definitely answered some questions with regards to SSRIs and pregnancy. I don't want to make it seem like what I think the panelists made it seem like was that there are so many more unanswered questions. And while there are still very important scientific questions to be answered, it's also important to highlight the fact that there have been pretty reasonable studies done where we can draw certain conclusions, even in the absence of the most perfect type of study design. And I'm going to talk about that in a little bit and some of the limitations of doing certain study designs in the pregnant population and in the obstetrical population. But without a doubt, as you guys know, and we have been champions of from the inception of this platform, is the involvement, the participation, the focus of medical research on women's health, and also specifically the focus of research on underrepresented populations, whether Black, Hispanic, Pacific Islanders, and the list goes on. So we definitely agree on those three major portions. It's a serious condition. Informed consent is very important with all treatment modalities that are offered to patients, and there is still an ongoing need for continued research in this area. Now let's talk about the areas where we diverge in opinion. So now I would like to focus on certain things about this panel discussion that really got me so concerned, where I was just like, America, girl, you're in trouble. So I say that because there definitely was what seemed to me a very clear agenda. And that agenda was to dissuade the public that there is any value in using SSRIs by, in some ways, misrepresenting the research that's out there by not offering a completeness in the discussion of the available research and some of the statements that were made by panelists. So the first thing you should do whenever you're listening to a panel discussion is one, who are the panelists? And this is very important because if you have a panelist that has a history of a certain perspective, then you know it's very likely that the information they're going to present is going to be of that perspective. You want panelists who are able to talk about the discussion from both sides. Medication, no medication. Medication, alternative interventions. So, step number one, who are the panelists? And this part I'm going to leave up to you guys to do your own research. It doesn't take much to find out more about the panelists that were on this particular panel. I will be freezing some of their pictures so that you can get their titles if you don't have time to listen to, I think it's like a 2 hour long panel discussion. You can definitely capture their image or their names and titles and do your own very simple internet search. It's not hard to find the history of these individuals because of the fact that they are known. Okay, so one of the things I thought was very interesting was just the composition of the panel, right? There is something very obvious when you look at the panel. I'm just going to leave the picture up here. Do y'all see anything? Anything striking about the panel? Well, here's something that may help to catch your attention as to what is lacking in the panel. One, we have that up to 30% of American Indians and Alaskan Natives suffer from postpartum depression, up to 30%, right? Then you have also that 40% of Black and Latina moms suffer from postpartum depression, twice the rate of white counterparts. Latina and Black women are 57 and 41% respectively less likely to start treatment for maternal depression compared to white women. There has been a 280% increase in postpartum depression diagnosis for Asian American and Pacific Islanders between the years of 2010 and 2021. Gen Zers are more than twice as likely as boomers to suffer from mental health disorders. Now, an important caveat to that is the timing of the pandemic, and we did see a significant rise in mood disorders as a result of the pandemic, which kind of makes sense, right? But nonetheless, when you think about the populations that are most impacted by these disorders, specifically looking at postpartum depression and perinatal depression, we find that the underserved populations, you're more likely to experience perinatal depression when you are experiencing poverty as well. And so, what's interesting is you have minoritized populations that are more likely to be impacted by postpartum or perinatal depression. But when you look at the panelists, need I say more? And this is not, again, this is not an isolated issue when it comes to mood disorders, because when it comes to the voice of the professionals who are most experienced with these underserved populations, it is oftentimes we're not included in these discussions. We are not invited to these panels. We are not given the opportunities to be in these academic centers, to have a voice in the research, to have a voice in the academic world. And the academic world is the world that kind of shapes medicine. That's where the far majority of the research is done and funded. And it's not to say that there aren't experts in this area who are people of color. There are very much experts in these areas that are people of color that are no less expertise than some of the resume of the panelists that were invited to this particular discussion. So that's one thing I do want to highlight. And before I go on, I should share with you to practice what I preach. Why am I a voice in this particular area? For those of you who are new to our channel, before I continue, please, please, please go ahead and hit a like on this particular video. And if you haven't done so, definitely subscribe to our channel, because on this platform, what we aim to do is to take these topics, dissect them out, and extract the information that's important to our community. And the community that we have built is a community that represents the underserved population, the minoritized populations. And because our story is unique, the way medications impact us is unique and understudied. The way we express different disorders is understudied and unique. And so that gives us a very unique voice in this space. We also take to heart the importance of really bringing transparency when it comes to medical information, the limitation of that information that's available. Our goal is so that our public has the ability to do exactly what I said. Have informed consent, be an informed public, be an informed community. So I am a board certified OBGYN in the United States of America. I have been practicing now for over 20 years. It's a long time. And so I have a couple of decades of experience under my belt. But even more importantly, I have the practice of medicine under my belt. And when we say the practice of medicine, meaning that we're actively caring for people in the clinical world, in a clinical perspective, and not from a research or bench perspective. I have had hands-on care for patients throughout my career, and I have been in various aspects of medicine, from the academic world to the utilization community, while maintaining a practice of medicine at the same time. But the bulk of my career has been in community medicine. And what that means is I am directly caring for individuals who are most likely to experience these disorders and most likely to be impacted by the limitation of resources available. So I can bring to you that perspective of medicine, which I think was lacking in this particular discussion. And in some ways, this discussion gave almost a utopia perspective of medicine, that if we take away the medications, that there's some utopia treatment that exists that will solve all the problems for those who are affected by this disorder. And that's certainly not the case. And I can explain to you firsthand why that is not the case. Also, there is not a single day in my care for patients that I do not deal with postpartum or perinatal depression and anxiety disorders. Every single day of patient care that I do, I am caring for at least one, and most often multiple, individuals that are impacted by perinatal mood disorders. And I have done so for many years. So I do think I have some knowledge of what this particular disorder is like and what the treatment of individuals who are infected by perinatal mood disorders are like. That being said, let's get into this. So when we're looking at the panel also, I want us to also pay attention to the expertise that's represented on the panel. One of the things that struck me was just the lacking of representation of the professionals who actually care for the women throughout their pregnancy and who are responsible for the outcomes of not just the women, but also the outcomes of the unborn child as well. So while the discussion was very psychiatric heavy, and of course the psychiatric community should be involved in the panel discussion, I, however, take pause on the idea that the psychiatric community should be the primary voice or the exclusive voice or near exclusive voice in this particular discussion. And that was very striking to me. Psychiatrist after psychiatrist and at one point, a biologist um, participated on this discussion, and there was only one perinatologist who was on the primary panel, and that perinatologist, I advise you to look into the history of that perinatologist's perspective on this topic. He has a very long history of his perspective. And there lacked a perinatologist that can have a balanced discussion on this particular topic. And while he definitely has made a name for himself in the field of perinatology, I found it quite striking that some of the leaders in perinatology, some of the leaders for the Society of Maternal Fetal Medicine, were not invited to this conversation. The leaders in the American College of OBGYN were not invited to this conversation. And not only were they not invited to this conversation, there was the implication almost that doctors take our information directly from the FDA, and somehow the FDA decision leads to doctors' decision making and then leads to patient care, when that's not at all how most doctors in the US practice medicine. Most doctors in the US practice medicine from the perspective of gathering information from multiple sources, and oftentimes including the ownership of some journal, our scientific journal that's well respected, whether it's JAMA, whether it's a green journal, that provide peer review scientific evidence. And so the idea that somehow the medical society as a whole are beholden to the FDA and are submitted to the FDA is quite a deceptive perspective. Um, Many of my colleagues, including myself, utilize multiple resources to obtain information and then present that information in an informed consent way to our patients. And while not everyone's experience may be like this, and I acknowledge that the approach to medicine is quite divergent depending on where you live, whether you're urban or rural, whether you're at a community hospital or whether you're at an academic center, whether you're on the East Coast or the West Coast, whether you're in the North or in the South, whether you are cared for by private insurance, whether you're cared for by federally backed or state-backed insurance. All of these things do impact patient outcomes. And I'm not at all ignoring that, but that too was not discussed or acknowledged in this conversation. Okay, let's take a listen to some of the clips, and then I'm going to comment on some of the things that were said. And I think that should help us get through this topic in a little bit more complete and digestible way.
Research supports this. Basic science research shows that SSRIs impact individual neurons and the developing brain. Many animal studies show that SSRIs alter the development of rats, mice, rabbits, and sheep. When those mammals grow up, they behave differently. Socially, their behaviors are described as autistic-like, and they also have altered sexual behaviors. And then there are the human studies. Numerous human studies show links to birth defects, miscarriage, preterm birth, low birth weight, preeclampsia, and postpartum hemorrhage. And many, many studies show impact on the developing brain. These drugs alter the mom's brain. Why wouldn't they affect the babies? We can see it on prenatal ultrasound. The ultrasound studies show SSRI-exposed fetuses have different movement and behavior patterns. After birth, the newborn babies can have jitteriness, breathing difficulties, and higher rates of admission to the neonatal intensive care unit.
So let's talk about what was shared there. And one of the things I would like to start with is the scientific research that's available. You will hear multiple panelists refer to animal-based studies. And while animal-based studies are of value because they're typically the studies that lead us to have the question or the scientific question that can then be answered in human studies, and oftentimes will highlight when there is a potential harmful outcome with a study before it is considered for clinical trials. Um, the idea that the SSRIs cross the placenta is true, and we have known this. This is not a hidden science. However, there are certain things that we do know when it comes to this, when it comes to these medications. And while the initial studies had certain outcomes, the subsequent studies that have been done have been much more informative and concrete in dispelling some of the earlier beliefs. So I'm going to go through a couple of the things that were mentioned. Let's start with the implication when it comes to neurodevelopment. First, it should be stated that a very small percentage of patients are actually on SSRIs during pregnancy. In fact, I can tell you my own practice that the far majority of patients will first be treated, or majority will choose to be treated by psychotherapy first, or some other type of mindful intervention before considering the SSRIs. And part of that is just simply because the far majority of patients do not have more severe disorders. They have mild or moderate disorders that can be adequately managed by other modalities. So the impression of doctors going straight to medications is just not factual. And that's actually not what the recommendation is by the professional organizations. When it comes to the neurodevelopment, it is true that we are lacking information. While we do know that biologically that there is a significant role for serotonin and its function in embryogenesis, in the neurodevelopment, we don't know what that actually concludes to. We don't know what the actual outcome is. So we know scientifically that there is a significant role. We know that the medication crosses the placenta, but a number of medications cross the placenta that have not been proven to have any adverse outcomes. So the assumption that simply because a medication crosses the placenta and has a particular role or biochemical role, that equals some type of clinical outcome is just a falsehood, and is misleading. Now, should we be studying this outcome more? Yes, because the data so far has been conflicting, and we don't really know for sure if there is an impact, and if so, what that impact is. Now, the other thing that I find quite interesting is the fact that um, the isolation of mentioning autism and the isolation of mentioning sexuality without explaining in what way someone's sexual health is maybe potentially impacted by these medications. So I do think that that was a little bit of a dog whistle to certain communities, a red flag to certain communities, so that they can jump on the bandwagon of believing that an association means causation. And I think that that is irresponsible. I think it's really important to, when you make these particular statements, to be very clear in stating that while there may be an association, there has been no proof that there's a causative effect between the medications and these particular outcomes, and also a true attempt of explaining exual health and which part of someone's exual health may be impacted. And most commonly, we're talking about decrease in desire, We're talking about lubrication issues. We're not talking about someone's sexuality or sexual identity. And I don't want that statement to mislead people to believe that that is what the science is showing, because that is not true. I also don't want it to be assumed that women who decide to take these medications are in some way making a very easy decisions or an uninformed decision. The women who decide to take these medications, and there's a number of reasons why some make these decisions. There is no one pill for everyone, figuratively speaking, because the decision making is just as diverse as the presentation of these illnesses. That being said, certain outcomes like neonatal adaptation syndrome is one that does exist where some neonates do experience a withdrawal. Similarly to neonates who may be exposed to um, certain medications that are given to those who are affected by drug abuse, and they may still have some type of withdrawal experience um, at birth or during the neonatal period. That is a outcome that's taken into consideration before starting these medications. And the reason why this conversation was very lopsided was because they didn't talk about, well, what are the risks of not being treated? And what is the likelihood of the success of having severe disease with the current alternatives that are available? None of this was discussed. Now, what's very interesting in this discussion was the heart defect conversation, right? And so they mentioned a heart defect without giving the updated information, which I thought was rather interesting. There was one study that initially linked heart defects to Paxil, which is one of the antidepressants that used to be commonly used during pregnancy. However, more recent research have not been able to find that same outcome with the medication. In fact, the more common medication that's used, fluoxetine, has not been associated with birth defects. And there have been a number of studies that have monitored outcomes that have yet to show that there is a causation or correlation with an increased rate of birth defects above what is the norm in the population. So there's a normal rate of birth defects that occur in the population that is sort of your spontaneous birth defects. And so whenever you take a medication or some type of intervention, it is compared against that standard or against that baseline prevalence. And one of the things that was not mentioned when it comes to neurodevelopment is the fact that what has been proven and what has been shown is that untreated mental health or untreated mental illness has been correlated with affecting the development of the fetus. And so someone who has a mental health illness or disorder and has not been treated is more likely to have adverse outcomes with their pregnancy for a number of reasons. So when a individual has a mental health disorder and they are pregnant, and we have noticed this with traumatic events, with serious or severe mental health disorders, they are more likely to have inadequate prenatal care. If someone is suffering from a mental health disorder, they're less likely to be consistent with their prenatal care, less likely to be consistent with the recommendations of their care, less likely to participate in healthy habits during their pregnancy, like exercising regularly, eating healthy. They're more likely to participate in unhealthy or toxic habits even. So someone who have severe or mental health or someone who has untreated mental health disorders are more likely to participate in unhealthy and sometimes even toxic habits. So the mental health doesn't go away. The disorder doesn't go away. And if we don't appropriately address it, they're more likely to take up smoking. They're more likely to start drinking to cope with their mental illness. They are more likely to have unhealthy exual behaviors, making their pregnancy more high risk. And it has been shown that individuals who have mental health disorders that are untreated are more likely to have preterm births and are more likely to have low birth weight outcomes. Not treating these disorders lead to very serious outcomes. And the other thing that's not mentioned or discussed is the familial impact. I have, as much as I have cared for individuals who have mental health disorders, I also am a part of the community that is more adversely impacted, right? And least likely to have access to help. And so I have personally witnessed in personal relationships individuals who have been affected by these disorders. It leads to loss of job, productivity. They lose familial relationships are affected. Patients who have severe depression may start to isolate as part of their symptom of depression, and that isolation breaks down their communication relationship not only with their partner, but also impacts their relationship with the children, their other children who are witnessing the severity of their illness, who are witnessing the lack of showers, the unkempt behavior. They are witnessing the isolation. And when that child shows up and the other children are seeing that mom is isolating with the baby, that can trigger resentment and unhealthy relationships between the siblings as well. That can cause just a dysfunction in the family that sometimes can lead to a breakup of family. And these are things that are not being discussed. The other important item that's not being discussed is the likelihood of hospitalizations. Someone who is someone who has an untreated mental health disorder is more likely to utilize the hospital, the ER. They're more likely to be hospitalized. And what's important for especially America to know is that there is a new executive order that is targeting the hospitalization or institutionalization of individuals who are substance abusers, who have mental health conditions, and who are homeless against their will. And so, if you have a policy that withdraws what has been proven to be an effective treatment for individuals who are affected by these disorders, and that lack of access to adequate treatment lead to their hospitalization in the setting of where hospitalizations now can also be without someone's consent, you're setting people up. And what's also not discussed, as much as they discuss the potential neurodevelopment impact of babies born to moms who are treated by SSRIs, there's no side to side comparison of untreated individuals versus treated individuals, by the way, when it comes to neurodevelopment outcomes. Nothing that has been concrete. And what we do know is biochemically, the offspring or the children of moms who have untreated mental health disorders have higher cortisol level. Some of you may already know that cortisol is our stress hormone, and that biochemical impact may have outcomes when it comes to behavioral health of the offspring. And we saw this in the studies that looked at women who were pregnant at the time of 9/11 and who were at the 9/11 sites and their offspring. 530,000 New York City residents suffered from some symptoms of post-traumatic stress disorder. They found that there has been at least 1,700 women who were pregnant at the time of 9/11, meaning they were either nearby or actually at the site of the Twin Towers. Further studies have shown that the offspring not only had behavioral outcomes or abnormalities, but also had biochemical abnormalities with these higher cortisol levels. So it's really important that we have a very complete discussion if we are really talking about giving women informed consent. Let's listen to the next clip. It gets better.
In his Face the Nation interview in June, Martin McCarry said, "We've got to let doctors be doctors." My point is we've got to get doctors to be doctors again, make doctors great again. Or we can opt to say, well, you can just dispense drugs.
Okay, y'all, do I need to say anything to that particular clip? It's an interesting commentary. Now the I will say the signaling of make doctors great again is disturbing, right? Because we know that that particular tagline is associated with a certain political position. And when we as clinicians are giving a panel discussion, it is important that we try our very best to not politicize the discussion. And you don't have to overtly politicize the discussion to get a certain propaganda across to the right ears. And the commentary of using a tagline that has a certain branding, that is a well-known branding and association with a certain political figure, is a whistle. And that whistle will be heard by the people it's intended to be heard by. And that, I would say, is one of the most disturbing statements that was made during this entire panel discussion. But there were others. It gets better.
From the heart, what I'm seeing in clinical practice, what I've seen since I've examined the research literature, I'm fundamentally against misleading people. And so when we talk about depression as if it's this illness, this discrete condition that we can identify, we are misleading people. There is no objective test. When you go into your medical centers, it's usually 8 to 10 minutes. If anything, you're going to fill out a checklist, and you're describing emotional experiences. So what has happened when we've medicalized all aspects of the human experience? Let's look at the fundamental data. Do you think we've reduced the burden of what we call mental illness? Are we better off as a society? You can't fundamentally provide informed consent, which is a legal and ethical imperative, unless you're willing to ask some of the difficult questions that I hope we ask today. If there essentially is no chemical imbalance, right, where a lot of the data is going to really suggest that we're fundamentally experimenting on developing brains, but we've changed our collective consciousness. We've brought things into the lexicon that previously weren't there.
Okay, so it's interesting to say that you fundamentally don't like to mislead individuals and then proceed to make statements that are misleading. That is to me. What's really interesting is sort of the flippant comment about standardized questionnaires. They're not checklists. You are not, when individuals are screened, and these screening questionnaires, just like screening questionnaires that we use throughout medicine, that is a reflection of patients reporting their symptoms. And yes, their symptoms are based on their feelings when we're talking about mood. That is inherent, right? It doesn't diminish the objectability or the value of patients reporting how they feel as a reflection of their symptom and the frequency of these feelings, which then equate to a scoring system that has been validated. So to minimalize the value of these questionnaires and calling them checklists is in of itself a very misleading statement. Yes, people's feelings are subjective. That is the essence of someone's feeling. But when we treat these conditions in medicine, we're not talking about someone who had a depressed mood for a day, because we all do, right? At some point, a sad event, someone who may be even appropriately grieving. That's not the individual who undergoes treatment. The individual who undergo treatment for mood disorders, the distinguishing factor between someone who's just having a life experience, as alluded to that statement, versus someone who actually has a disorder is the impact the disorder and those feelings have that then lead to some type of dysfunction where the person is isolating, they're not eating well, they're not sleeping well, they're no longer productive, they can't focus, they can't concentrate, so they can't work, and they can't take care of their selves. They're not taking baths, they're not cleaning their home, they are not taking care of their children, they are not going to work. They are not able to interact at work. They're not able to do the things that they normally do that is considered to be activities of that's considered to be activities of daily living. So the distinction is someone who has a mood or in a certain mood and someone whose mood now has significant impact on their life. That is where the treatment is targeting the individual who can no longer function because of their mood. And the implication that somehow there is a lack of scientific basis for these disorders is really concerning to me.
Or are women just naturally experiencing their emotions more intensely? And those are gifts? They're not symptoms of a disease?
Now, this statement, I need to play twice. Listen, tell me you've made a misogynistic statement without telling me that you've made a misogynistic statement. Y'all, I could write a thesis on this, but I'm not going to write a thesis on this. I'm going to say this very simple and very straight. To the individual who made this statement, that women just simply have more intense emotions. That is the whistle of saying that women are more emotional. An individual who have more intense emotions is a synonymous way of saying these individuals are more emotional. And your gaslighting isn't working by turning around and saying it's a gift, because what you then turn around and say is that that gift needs to be treated, but then you don't offer the treatment that that gift requires, and then you hospitalize us, or you say that we're crazy. This statement, you guys, is probably one of the most egregious statements that was made in the entire discussion. And there were many, but this statement right here, the fact that he said it so easily off his tongue, like it was some type of epiphany, when it just really is one of the most misogynistic statements that any practitioner can make. The fact that you believe that women have more intense emotions, there is no scientific basis for it, but yet you overlook the reasons why. Objectively, you talk about objective findings, but made a very subjective statement and overlooked the actual objective facts. The reason why women have more prevalent outcomes could be as a result of the experience of being a woman. See, you've now made this disorder something that's internally inherent to womanhood, when this disorder has not been proven to be such. In fact, this disorder is more likely to be a reflection of the stressors that are unique to womanhood. Women are more likely to have a number of experiences. Women are more likely to, for example, experience pregnancy and a lack of support during pregnancy, and in this particular United States of America, have a high mortality rate for the simple fact of giving birth and having child and bringing life into this world. Women are more likely to experience sexual abuse. Women and girls are more likely to be trafficked. Women and girls are more likely to experience inequities from the time that we are born to the time that we return to the grave. Women are more likely to be underpaid compared to men. You guys, I just had to add an additional difference that I did not mention. Women are just more likely to go to the doctor and get screened. Women are less likely to have support when it comes to motherhood. So when you say that women have more intense emotions, but lack the evidence behind it and ignore the facts that explain why there is more of a prevalence in women than men, you internalize the problem to be a woman's problem instead of acknowledging the societal factors that increase the prevalence among women compared to men. And that is why that statement is one of the most misogynistic statements made during the panel. And before I forget, because they mentioned the postpartum hemorrhage like it's a fact, but it's not a fact. You guys should know that there was a major study that came out of Europe, I think it was Sweden, that actually was the largest study that looked at this outcome and did not find that there was a link or association between SSRIs and postpartum hemorrhage. There are other smaller studies that showed that there may be an association, but there are other factors that were not controlled for in those studies. And when I say control, what I mean is in order for a study to be taken more seriously or where a study outcome can be truly accepted is when it accommodates for other outcomes, for other factors that can lead to the same outcome in the same population. So if I have a population that has two factors that can lead to the same outcome, but I say simply because they have factor A and they had the outcome that the study was looking for, and ignore the fact that the same group of people were also more likely to have factor B, then that is not a study that is considered to be valid. It's a study that has biases. And so the fact that they mentioned a postpartum hemorrhage, but didn't really give the public the actual data findings behind it is really concerning and kind of shady. But we see y'all. We see y'all. Now let's go on to the next clip. It gets better.
Our care has become very transactional. Oftentimes, women will get 5 to 10 minutes to see a doctor, and often practices are not profitable unless the doctors are seeing, 3 people an hour, something like that. There's not a lot of time to do all of the things that we wish that we could help them with. There are women coming in who are unhappy because they're juggling careers.
Okay, we can actually agree on this one, right? We can agree on the fact that we have said this repeatedly on this platform. We need more time to see women. We need more time to take care of patients. We need more time, especially when it comes to these particular type of disorders, because let me tell you guys, it is not easy for people to disclose that they're experiencing these disorders because there's still a level of shame, personal guilt, especially when it comes to motherhood, the challenge and the feeling of inequity, the feeling of inadequacy, the feeling of shame is oftentimes a barrier that leads women not to disclose these disorders. And so it's really important that we have the time to develop the relationship that it requires, that we can create a safe space for individuals to share their concerns. So I'm going to agree with that point. We agree on that.
So what are the solutions? Well, I think for a long time we've taken a lot of pride in this country about being the epicenter of pharmaceutical development. And I think we should be proud about that. But we should also take a lot of pride in informing the people who live here, our citizens, about the risks of these medications. And we can do a much better job. And so I think FDA is really well positioned to start getting a bit more creative about how we can inform people about the risks of these medications within this time-constrained system that I think everyone listening and in the audience has probably experienced. I've put up an example up there. I mean, if we can get QR codes with patient-friendly videos talking about the most important risks right on the bottle cap that just says, "Watch me," just like this picture, we could just do wonders, just having something just there where people can see and they can learn about the risks. We need to start getting more creative in how we're informing women. Thank you.
Okay, y'all, I had to stop it right there because did you guys notice that throughout, and you will see this throughout the whole panel discussion, people are mentioning, oh, there are other solutions, but nobody actually shared what those other solutions are. Oh my goodness. No one's actually sharing the efficacy of SSRIs, right? They're casting doubt on certain aspects, but there are studies that significantly show that SSRIs are very effective in treating these disorders. In a matter of fact, in treating these disorders. But yet still, they talk about there are other forms of treatment and there are other options, but no one actually talks about what those other options are. There is such a huge gap in this discussion. And let me tell you, we want those other options. We want there to be more access to psychotherapists. We want the availability of more support groups that practice mindful activities. As you guys know, on this particular platform, we have shared that mindful activities when it comes to anxiety disorders, that they are not inferior to anti-anxiety medications. We have shared that. We want those options to be effective. But you also have to show that in the most serious cases, that these modalities are sufficient. And the research just has not shown that, right? Not to mention, after the pandemic, when there was a surge of mental health disorders, people were on wait lists to be able to have access to a therapist. There was a shortage, not just locally, but nationally. Even with some of your virtual platforms, there was still a wait list and difficulty of individuals getting help. So you can't create this utopia for the population by saying, yes, all these other modalities work, but then you have populations that don't even have access to it in this current day in time. They do not have access to a therapist. They have to wait on wait lists. And this especially is impacting the rural communities that have a much lower ratio of therapists to the population. So when you have this critiquing of this of SSRIs and medications that have been shown with a multitude of observational studies to show their safety and efficacy. If you're going to critique these options, and it's okay to critique, but make sure your criticism is substantial and has support and is a balanced conversation. And part of that balancing of the conversation is by making sure that there is access and equity of access to all populations. And a matter of fact, on a recent discussion, our licensed professional counselor, Janae Mitchell, also mentioned in one of her commentaries that one of the key elements that's needed by postpartum moms is sleep and support. I'm a mental health counselor, so yes, there are some postpartum anxiety or psychosis. There are real things that could happen, right? But for the vast majority, the postpartum depression, the baby blues, the postpartum anxiety is truly brought on from a lack of sleep and the lack of support. Say it one more time. And with sleep and support, a large percentage of women will not experience postpartum mood disorders. And I happen to agree with that. I don't know what that number would be, but I do know in my own anecdotal experience that a lot of times the main factor that is, if not the factor, the trigger, but definitely a significant contributor to these outcomes is a lack of support, especially a lack of a supportive partner, the lack of maternity leave, paid maternity leave. Let's talk about that. If we want to provide options that actually have already evidence of having a positive impact, then we need national maternity leave, paid maternity leave. Then we need support services like doula services that have been shown to improve the outcomes. We already know this. But there is no balanced discussion to say that these services are going to be provided, that these services are going to be funded, that we're going to create support systems and networks that will help to fill in the gaps for moms and for these families that are impacted by these disorders. And that's the problem. On a side note, I find it quite interesting that some of the panelists aren't even American experts, and there are plenty of experts in America. So why are they not on the panel? Wondering minds want to know, but let's move on.
Repeatedly told that antidepressants are effective, that they save lives, that they transform people's outcomes. But the data on which these claims are based really doesn't support.
Okay, I'm going to stop it right here because I find that to be a very interesting commentary, right? Simply because there is a huge meta-analysis that was done, and meta-analysis is a review of currently available research studies. And they use a particular criteria to make sure that there is consistency enough amongst the studies that they can draw a conclusion. And this meta-analysis actually looked at the impact of the impact of the suicide rate with individuals who were treated with antidepressants. And what they found was that the rate of suicide peaked before the individuals were on the antidepressant, not after. And in fact, there was a significant decrease in the rate of suicide in individuals who were on the medication. So I find it quite interesting that the expert is saying that there's no correlation or no data. And this meta-analysis, which was not done on a pregnant population, but the statement was made as a general statement. So I'm address it as a general conclusion. The statement that there is no correlation between the medications and the efficacy in decreasing the suicide rate is just not consistent with the data and information that I have found. So this meta-analysis, which was published in 2024, looked at a number of randomized double-blind trials because they've been using the randomized double-blind as a signal to imply that the other studies are lacking value, when that in of itself is deceiving. But anyway, this meta-analysis does exist, and it has shown that there is a efficacy of the medications in reducing the suicide rate. So I'm very perplexed as to why that comment would be made in light of the evidence that is currently available. That's all I got to say on that. But let's talk about the fact that they keep talking about randomized controlled trials. And yes, randomized double-blind controlled trials are sort of the golden standard of studies, is sort of the golden child of study designs and the ideal type of study designs where you minimize the type of biases that can naturally occur in different types of trials, which a bias is just a fundamental error that could occur that can decrease the validity of your conclusion. So people who have recall biases or biases in selection of the population that was being tested or studied. There are a number of things that can affect the outcome or the conclusion of a study, and we try to minimize these things so that the outcome is truly one that you can hang your hat on, the outcome that is considered to be valid. So yes, it is very hard for the obvious reasons. There are very few things that are studied in the pregnant population for the obvious reasons that are randomized double-blind control trials. Which pregnant patient is going to sign up for a randomized double-blind control trial that has not had a pre-study that document extreme safety. It is very difficult to get those trials approved for the obvious reasons because of the significance in the outcomes. But it's not to say that without randomized controlled double-blind studies, that the current studies that are available that are either registries where you have women self-reporting, just like we did with vaccines, where you're able to go publicly and look at the registry to see what type of outcomes people are experiencing, what adverse effects people are experiencing. These are self-reports. So um, there is no incentive in reporting this. It is individuals who want to report their experience, bad or good. People report all sorts of things, all sorts of side effects that they've experienced. And it's up to the medical community to look at the reported information to see if there is a trend that then needs to be studied, formally studied. That's how those registries work. Or if there is a trend that's so concerning that the medication needs to stop and be taken off the market, so that additional studies are done. And the reason for that is while studies can be well done in clinical trials, there's still limitations based on the type of study that's done, that when that medication is then distributed in the population, you may have things that weren't controlled for in the clinical trial or experienced in the population that was studied in the clinical trial that the general population is experiencing and may indicate the need to stop a medication for further evaluation or just because there is a very concerning outcome. We try to minimize that as much as we can, but science is not perfect. There are some things that will end up having, and it's very few, but there will be instances when that will happen. Observational studies. Yes, they have their biases because they're observational. So people may be biased towards thinking that the medication works and report better symptoms, or it may be the opposite. But if you have sufficient observational studies that are showing consistently the same outcome, then you can actually draw a valid conclusion. It is when you have inconsistencies that those type of study designs are very limiting. So that's what's not being explained to the public as a part of this panel discussion. So the one thing I do want to make it very clear is that the medical society do not think that SSRI is a cure or for some reason a panacea when it comes to mood disorders, especially perinatal depression. We do not at all think so. However, it is the best medications we have available to us at this time that has been one of the most studied medications when it comes to pregnancy that can effectively help to treat individuals who are experiencing perinatal depression and other mood disorders. So we don't think that this is somehow this miracle drug, not at all. In matter of fact, most clinicians don't think drugs in general are miracles, but they are options available in an imperfect world to help individuals who have significant disorders or diseases that are impacting their ability to function in life. And it's up to the individual to decide whether or not the side effects or potential side effects of a medication, even if it's just Tylenol, even if it's just aspirin. And I don't want to say just because all medications is a medication and have potential side effects. But I use those as examples because they're probably one of the most accepted medication that's used commonly in the public. But all medications have side effects. All medications have benefits and all medications have side effects. It's up to the individual to receive the broad information necessary, including when we feel that the information is limited, to then make their decision as to whether or not they feel that their disorder is severe enough or that their symptoms are bothersome enough that they do want to accept the potential risk in exchange for an improvement in their disease or their condition or their disorder. So we do not at all think that medications are a miracle. We think medications are a help, that they are an alternative, that they're an option for treatment. And that is the difference. While I value the fact that we're finally having these discussions, that we're finally having some type of discovery, questioning, clinical, critical thinking about these particular topics, I'm disheartened with the approach in which this panel was done. I think that there were some very huge missteps, and I'm not by any stretch of the imagination an expert in the area, but I'm very well experienced in the area. But if you're going to be considered an expert, then you should be able to have the conversation from both sides. Let me show you an example.
Based on the current literature that we have, which is agreed upon by many professional societies, including the American College of OBGYN, the Society for Maternal Fetal Medicine, the American Psychiatric Association, there were new guidelines in 2024 from the Canadian Network for Mood and Anxiety Treatments. The risks of untreated mental health conditions are significant, and SSRI should be considered as one of the treatment options with shared decision-making with our patients. The panels raised concerns related to SSRI use in pregnancy, but when we review the literature and account for the confounding variables, comparing patients with depression who are untreated versus patients who are with depression and medications, we actually see that the risks are very similar between the two groups, with the exception of neonatal abstinence syndrome, which we can talk about. As an obstetrician, I care for two patients at the same time. I must always consider both the mother and the fetus and weigh the benefits and risks of my decisions and the patient's decisions for both of them incongruent. We definitely know the risks of untreated depression and anxiety in pregnancy. 1 in 5 women will have a perinatal mood disorder. Psychotherapy and SSRIs are tools that we have in our armamentarium to make a positive impact in the lives of mothers and infants. I want to stress that treating mental illness in pregnancy is not a luxury, it's a necessity. Just like we would not withhold medications for preeclampsia or medications for diabetes in pregnancy or blood thinners in pregnancy when women have blood clots, we should not neglect treating mental health concerns. Early identification and interventions positively impact both mothers and their babies. The goal is to achieve a balanced approach where the mother's mental well-being is prioritized and potential risks to the fetus are minimized through shared decision-making and close monitoring.
So this was the only voice on the panel that represented just really where we are with data and the limitations of data and what we have noted and the importance of treating these conditions. And so while I am thankful that we're having these discussions, I'm so disheartened and so concerned that the public was given a very um, biased conversation. I mean, there's no real other way of putting it. This discussion was not at all a discussion that was transparent. It was the discussion that has a specific agenda, that used certain taglines, that used certain tag words to signal to the public certain messages that were very much propaganda. It is very concerning that this was presented as a transparent conversation when it really was propaganda masqueraded as truth. It really was a discussion that was heavily from the perspective of individuals who may be experienced in terms of their years in the field, but have histories in which they have very specific views on this topic and have consistently had these views in this topic. To have a really helpful discussion for the public, when we talk about informed consent, which was the tag word used throughout this conversation, yet this was not an example of informed consent because they only talked about one side and did not give the other side of the conversation. And when we want to give the public the complete view of a topic, There must be individuals on the panel who are able to look at it from both sides, who are able to say, yes, this, but that. Who are able to say, we have this information, but not that. And not given this one-sided view. It is so disheartening and it is so discouraging because it feels like there is a specific agenda and certain words were used and tag words were used, such as autism, which is a trigger word for the public. Exuality was used, which is a trigger word for the public, but wasn't adequately explained. And so it's just so disheartening that this conversation even took place. And in essence, I think this conversation was way more harmful than it was at all helpful. That being said, I hope there's so much more I can talk about, you guys, and I was trying to just give you some bite-sized perspective on this conversation because it's definitely going to be an ongoing conversation. You can see that there was not only the discussion, which was supposed to be focused on SSRIs or antidepressants in pregnancy, there was some overarching comments that were made about antidepressants as a whole, comments that were made about depression as a whole. So you can definitely get a clear sense that the motive or the goal, I can't talk about someone's motive because I can't see their heart, but it sounds like the goal of this conversation was to revamp all SSRIs, all antidepressants. And if that's the case, if they're starting with pregnancy because people are more sensitive about pregnancy, it will garner more ear and it gives a platform for them to then present these overarching opinions. That is what is harmful to the public because you used a certain population and still haven't presented any policies or any solutions that addresses the population's issue with formal solutions. There has been no solution presented by this panel, yet there were mentionings of some solutions existing or alternatives existing without thorough conversation as to what those alternatives are and how you would implement them to actually care for the population in need, which in this conversation was supposed to be pregnant women. But the comments were way beyond just pregnant women. They were talking about antidepressants, period. They were questioning whether or not there really is an impact on the neurotransmitter of antidepressants in individuals. They were utilizing in vitro, meaning laboratory results, and drawing in vivo, meaning in the human population conclusions, which you can't do unless there's substantial information, which there isn't. There were conclusions being drawn without providing the scientific evidence to really prove those conclusions. So you can draw questions, which we all do, that need to be answered about antidepressants in pregnancy, about depression in pregnancy, but you can't replace it with conspiracy. You can't replace the scientific data with conspiracy and theories that are not yet proven. That's the concern. Your criticism can't turn into a theory and a conclusion. It's a criticism. Without the scientific backing, it is literally just a expert opinion. And opinions should never be the basis of health policies. All right, that being said, this is Dr. T, the hand behind the handle of Healthy Bump Club right here on YouTube. Oh, I forgot my hand. This is, see, y'all got me all hot and bothered, or what they say, what? Emotionally intense. I'm over here having intense emotions about this topic. Oh my, y'all. Let me go sip on my tea. I will see y'all later. It's Dr. T, the hand behind the handle of Healthy Bump Club, right here on YouTube and healthybump.club on Instagram. We thank you guys for watching and hope this was helpful to digest a little bit more of this information, this very controversial topic that shouldn't be controversial, but it is. Nonetheless, I hope I helped you with understanding this topic to a much greater degree. And for those who are out there who are seeking for help, listen, you do your research. You ask your doctor questions. You take your time when making your decision. But don't let these people fool you. under the guise of transparency. This is Dr. T. Just a friendly reminder, don't forget to comment, like, and share. And go ahead, why not? Click that subscribe button. Help us to get to the next 1,000 subscribers. We thank you guys for supporting.